So hello everyone. Thank you so much for joining us today. I want to share this case because I believe it's very interesting to show it how to do and how deal with this kind of situation. This is a 40. ¿Cuántos años tiene? So a 45 years old woman that came because of cholangitis, and um, there is a problem here in the cystic duct. So there is a I'm now with a cholangioscope, 9 French cholangioscope. This is why it's very important to have different size, because sometimes it's very difficult to achieve these areas. Okay, so I'm here with what's your name? Paul, my fellow from Peru, right? What part of Peru? Lima. So he's my fellow from Peru, and we were discussing about what have to do with this case. So initially we try to remove using a balloon, and the problem is that the stones didn't get out, and for sure the pain and the cholangitis is coming from this area. So the problem is that you can see there is a big inflammation, here in this area of the cystic duct, that it make impossible to the stones get out. So what is the best strategy in this kind of cases? So you have, if you don't have, well, the best here is you can try to take a basket. However, this space is not too big to do it, to make a lithotripsy with the basket. Okay, is one of the chance. However, sometimes not so easy because of the space. So the basket will not open well. And the second option is to try to put a stand if you don't have a cholangioscope, just to for 2 months or 3 months, and then retake the patient. It put more high costs, right? And the risk of that the patient doesn't goes well and continue the pain or cholangitis. Probably we don't know. But the third and the best, I believe, right now, is to make a direct evaluation using a 9 French cholangioscope. So now I am using a 9 French cholangioscope because the 11 French will not pass very well here, and will be difficult for the maneuverability. But you can see here that with the 9 French I have good maneuverability now. So now I am trying to do a stone lithotripsy, right, of all the stones, and will be easier to treat. So in one simple step during cholangioscopy and ERCP together, so we can try this kind of cases, with good effectivity. So now I'm using the walls lithotripsy, right? You can see here. And I will ask to my fellow, aplasta el pedal, por favor. You see? Dale, sigue. Sigue. Un momento. So now I'm trying to destroy the stone. Maybe some bleeding because of inflammation areas, but you need to clean up, okay? So now I believe I start to broke the stone. And in a gentle way, I will go inside, you see? So now I start to broken, you see? So that's why the basket will not work here. So we were discussing also to use the basket from the cholangioscope to try to remove it. It will be impossible. Is if you want to remove a big thing through a small window. This is why you need to make always strategies when you are trying to make any kind of treatment in the biliary tract, in the GI tract, or esophageal lumen or whatever, always is about strategies, and you need to have very clear what kind of a strategy you will use for each case. You see, now we are destroying the stone because the stone were not, I am using a lot of power here. The stone were not easy to broken. You see? So now the stone is going out alone just because of diminish the size, destroy the size, and then it's easier to pass, right? So ERCP or cholangioscopy doesn't need to be difficult. I sometimes I do not agree with the guidelines in some kind of way, because if we go step by step, sometimes with the guidelines, sometimes we didn't achieve. We lost more money because we expend more money. We use a lot. We can make some kind of complications also. And when you have an easier way and a strategy to make a good treatment in this case, right? You see, biggest stone impacted inside the cystic duct. That's why the patient is having this problem now. You see? So now you believe me, right? Okay, ahora sí me cree. That's good. So we were discussing with my good friend Ken B. Muller the other day. So hello, Ken. I hope that you see my video. But if not, it's okay. We were discussing about, that in the future for sure, direct access, by cholangioscopy is the next generation, of treatment, and not doing more ERCPs. Well, we will continue to use the duodenoscope and all these things, but I believe the exploration of the biliary tract needs to be the first step in the future, because we can have access to everything. We will not lost. So I need to retake my position now. Okay. Oh, it's here. That's the okay. Now I'm here. I'm sorry, I had to. Ah, okay. So now, so it's a big stone here. Sit aquí. So I believe I am no more in the. Oh no, I am a cystic duct. See, yes, I am here. You see a lot of stones, huh? That will not be easier to remove using just a simple basket or a I try always with the balloon first. If the balloon doesn't pass, I always believe that if the balloon doesn't make anything, so the basket sometimes will be difficult also, especially in the small areas where you don't have space to open it. Because the basket need to be very well opened, right? Remember that. So we need the space. We need to deal with the space. So if you don't have a space, you need to do in this way. So one case that has not been, this case I believe was treated before in another place without good results, and this is good, right? This is good to show it that we can do it, but it's always a strategy is the best. So I destroy a lot, but there is still one stone behind this, right? That is big, and I need to destroy it. Let's move, move. You see, just with the water, it moves. So I want to remember you that this year we will participate on Endoscopy on Air. So for the first time we will have Endoscopy on Air Americas, that is leading by my good friend Mowen Kashab. So we will have the first Endoscopy on Air the Americas from SOBAD, Brazilian Society, in April. So you can be connected. So for Brazilian and Portuguese speakers, that will be very nice. So we will try to show and not to do like a difficult case. I don't know how will be that, but well, in Brazil, how the organization is doing that. But we want to show this year in Endoscopy on Air, standard things, simple things, how to do it, some kind of treatments, that can be easier to perform by all the endoscopies, right? I want to show that. So now I am advancing inside. I am continuing the cystic duct, you see, and I want to destroy more the stones because of the inflammation of this area. I need to really almost done, huh? Today I will have another transmission, so I would like to invite you to stay connected and to put, a like, a finger up for I need, no, necesito que esto, escúchame, así, ¿ya? Si no, no funciona. Y esto tiene que estar mejor arreglado. Nelly, Nelly, ayúdame con algo, arréglame bien acá los pedales. No, 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 no necesito otro pañal, necesito que me arreglen los pedales. Ponte guantes, por favor. Solo ponme este aquí al frente y este al otro al frente. Y tú vienes más acá, eso es todo. No, 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 el azul, no, estos dos. Ahí al centro. Eso, gracias. Muy bien. Y ese también ahí. Eso, perfecto, ¿ves? Y si tú vienes más acá, no pasa nada. ¿Ok? So position is always very important, huh? To work. Very hard stone, huh? Normally these stones are easier. Pújalo un poquito. Necesito verla afuera. Ahí fue. No. Suelta. Necesito verlo. Sí. Okay. So imagine if I, with my lithotriptor, very high power lithotripsy, right? I'm doing this and it's becoming difficult. So imagine with a basket. Difficult, right? Very important to clean, to see. Okay, now I need a little bit of contrast. Necesito ver el contraste, por favor. Vamos a poner contraste. Ok. No, vas a pasarlo por los lados, por el lado del agua. Por allá. ¿Esta manguera para qué es? Pasa. Pasa por ahí. Pasa por aquí el contraste. Pasa por aquí el contraste. So now we are seeing very well. See, I will less to put more contrast because I need to see how the stones are now. Sí, por favor. Y necesito un balón de dilatación de vía biliar. So now I believe the stones are broken. Now I feel more confident. So what I will do now as the next step, to make easier this, you see, very well, is this is a cystic duct. There were a lot of stones impacted inside, and that's why. Okay, now I will less a guide wire, so retira el lithotriptor. So now I am very confident now. So it's very good the image now. So now I believe I finish. I will pass a balloon dilation. I will use a hurricane, right? Balloon dilation from Boston Scientific. La guía primero. So I will let the guide wire inside, in place, right? And then I will pass the hurricane balloon. And that's all. I will make the dilation in this, cystic duct that is very, very thin because it's inflamed because of the stone that were impacted there. That's why the pain of the patient and all the things. And then I will pass a balloon and I will remove everything. Okay? Okay, perfect. Now, sigue empujando. I will start to. Empuja. Necesito la imagen de colangioscopía. Sigue. Okay. So you see, some of them already get out alone. I think there is a. Empuja, 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 empuja. Está frenado. Okay. Okay, now I'm perfect now. Okay, oops. Perfect. Okay, empuja. La imagen endoscópica en grande, por favor. Coge una gasa siempre, hija. Si no haces todo eso que está pasando ahí abajo, ¿ves? Y a mí no me gusta. Balón Hurricane de vía biliar, necesito. You see all the stones that we take out, but this is, some of the stones that will remove it alone after lithotripsy. So sometimes just with aspiration it came out. You see? Look. Sí, dame. Sí, está bien. And then I will pass the balloon and I will remove the stones. That's all. So just to summarize, always you need to understand what is happening with the patient. Once you detect what is the problem in the patient, you try, yes, to remove it, but you need to think about, if you will use a basket or not. So I don't like too much the basket because I'm not so good to fishing, right? To make fishing. I'm not so good, so that's why I prefer balloon. But if balloon doesn't make anything, so think about that probably there is something that will not let you work very well. In this case was inflammatory stenosis that was, doesn't make the stones get out from the cystic duct. So what was first for sure, I believe, the stones that were starting to stay trapped in the cystic duct just, and then start to grow up. So now, okay. So now I will make a balloon dilation here. Inyecta, inyecta contraste aquí. Acá, contraste. Yes. Okay, ahí vamos a dilatar. So now I'm sure that I'm in the cystic duct and in the area. I need to be very sure that I'm in the area, but I am guiding because of the air on the common bile duct. You can see there, right? And then I am in a good position now. Dilata. Sí. Sigue, sigue, sigue. Todo, 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 todo. Todo, todo, hasta 12. Sigue. Ok, desinfla. Ahí, dilata. Dilata todo. No, hasta 12. Ok, perfecto. Desinfla. Ok, perfecto. Desinfla. Ok, dame el balón. Así. I just wanted to be sure. So now my balloon will pass. Hannah. Now I will use extraction balloon. I will inject and then I will remove everything. Ten, 10, 10. Okay, injector, contraste. So we'll inject contrast now. Inyecta. Dale, dale, con ganas, todo. Ok, infla el balón. Empuja la guía. Ok, ve desinflando poco a poco el balón. So now I am deflating the balloon because I need to, you know. Okay. Okay, desinfla. Right. Infla el balón. You see? Okay. You see the stones are coming, you see? A little bit. The fragments are coming out now. You see? Very good. Now I'm okay. Now I'm happy. Okay, perfect. You see? Now the stones are going out, which is good. Perfect. Ok, ve desinflando solo un poquito. Ok, salió. Perfect. You see the fragments are coming out. I believe we already finished. Okay, infla el balón, inyectemos. So now we make a cholangiography. And probably I will pass again the cholangioscope just to be sure that everything was removed. And I finish. So this is very important. First, because of the time of the procedure, so you diminish the risk of more anesthesia in the patient. Second, you work quickly in a faster way, right? Very good. Okay, desinfla. Desinfla. You see there's some breast that will get out alone. Now I want to inflate here. Injecta. 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 Okay. So there was the gallbladder is there with a lot of stones, and that's a problem. So now, what I will do now is I believe this patient needs a surgery, right? Because it's a lot of stones inside the gallbladder, and this is a chronic cholecystitis. This is a problem of this patient, and it was a chronic cholecystitis because there was impact, a lot of stone there. Now that I have access to the gallbladder, I will let stand here. Pigtail, ¿tienes un pigtail? De 7 por 5 o algo así. Empuja. So now we put the double pigtail just for drainage, and I believe we'll be fine. So empuja. Sí. So at the beginning, we didn't have access to see the gallbladder. The gallbladder was really high because of the stones impacted. That's why the problem of this patient. So the problem was not the stones in the common bile duct. The problem was the stone impacted in the cystic duct, and this is how we need to solve the situation, right? Now with this will be a relief in the pain, and will be a relief of the cholangitis, of the cholecystitis. So this will be a good bridge for surgery. Okay. 7.5. So I will put a 7 French 5 centimeter um, double pigtail. Yo creo que directo en la guía. ¿Eh? Directo en la guía. Solo me pasas el catéter para empujar. ¿Cómo? Aquí. Sí, directo aquí en la guía. No, tienes que ponerlo recto con el tubito. Ok, primero ahí, despacio. Empuja más. Solo ve la punta. Cuando veas la punta, ok, retírala un poquito para que tu punta esté recta y ahí pasas la guía. Y del otro lado va a ser lo mismo. Cuando lo sientas ya que está llegando, lo que vas a hacer es empujar para poner recta esa parte. Eso, sigue, avanza, avanza. No, no, avanza esto hacia adentro para que la otra parte distal se rectifique. No, no, perdón. Yo lo hago. Esto es lo que te estoy diciendo. Ahora sí, empuja tu día. Eso, déjamelo ahí. Ok. Jala, empuja. Puede ser el esfinterótomo si quieres. El empujador mismo de la prótesis. Sácale esa, sácale a eso, sácale. No, no, por el otro lado, hija, por el otro lado. Sácalo. So now I have my stent. Now the gallbladder is relieved and the impacted stones were cleaned. So now we are fine, and now we will finish just putting this to send the patient easier to a better recovery, faster recovery, and put cold her situation now and send into surgery because she have chronic cholecystitis. That's why it's not distensibility. You see, I can see because it's not, there is no distensibility in this gallbladder. That's why it make me think about. Okay, libéralo. So perfect. You see, I have my stent. I relieve my gallbladder in an easier way, and now the patient will be fine. Now we make the aspiration, and that's all. So thank you so much. I will join you in the next case that I believe is very nice, what I want to show you today. And that's all. Finished. Thank you.